Bismillah Rahman Rahim. Hello everyone. You know that we have been doing non-communicable diseases from community medicine point of view, and we have done some diseases, specifically the cardiovascular diseases. Previously, today we will be discussing diabetes mellitus, another one of the non-communicable diseases. So, diabetes mellitus is a heterogeneous group of diseases, not a single disease, and it is characterized by a state of chronic hyperglycemia resulting from a diversity of etiologies, which may be environmental or genetic, and they may be acting in combination jointly. The underlying cause of diabetes is the defective production or defective action of insulin, a hormone that controls glucose, fat, and amino acid metabolism. You know that it is produced by the pancreas. Chronic hyperglycemia from whatever cause, may that be from the defective production or defective action of insulin, it leads to several complications. These complications may be cardiovascular in nature, or renal, or neurological, ocular, and some other concurrent infections, or all of these together. Diabetes mellitus is further classified clinically into three types or varieties. And the first one is the diabetes mellitus. Then there may be impaired glucose tolerance, and the third one is gestational diabetes mellitus. The first type has further subtypes. The diabetes mellitus may be of type 1 or insulin dependent diabetes mellitus, type 2 or non insulin dependent diabetes mellitus. It may be malnutrition related diabetes mellitus, or it may be some other variety of diabetes which may be secondary to pancreatic hormonal drug induced or genetic abnormalities. Let's discuss these in detail. So remember, we are looking at diabetes mellitus from a community medicine point of view. We won't be going into its pathology or its clinical manifestations or the management. We are just looking at diabetes mellitus from public health point of view. So type 1 diabetes mellitus is insulin dependent diabetes mellitus. It is the most severe form of the disease. Its onset is typically abrupt and is usually seen in individuals less than 30 years of age. It may prove to be lethal if not properly diagnosed and treated. And this form of diabetes is immune mediated in 90% of the cases, and it may be idiopathic in less than 10% of the cases. It occurs mostly in children, although it may happen in adulthood as well, but mostly it occurs in children, and the incidence is highest among 10 to 14 years age group. Exogenous insulin is required in this type of diabetes to prevent the ketosis, which may result due to increased glucose levels in the blood, and also to reduce hyperglucagonemia and to reduce blood glucose. Type 2 diabetes is much more common than type 1 diabetes, and it is often discovered by chance. The person usually does not know that he or she has had diabetes for some years or some months, and it is purely by chance that usually the type 2 diabetes is discovered. It is typically gradual in onset. There is no abrupt onset as was seen in the type 1 diabetes, and it occurs mainly in the middle-aged and elderly. Again, the age group differences is there. It is frequently mild. The ketosis development is slow, and the survival can be long in type 2 diabetes mellitus if adequately treated. Its clinical picture is usually complicated by the presence of other disease processes. Then there is the impaired glucose tolerance, IGT it can be called. It is a state in between the diabetes mellitus and normality. Uh, the person is neither diabetic nor he or she is normal, but he or she may be at risk in the at-risk group, which may go on to develop diabetes mellitus. It can only be defined by oral glucose tolerance test. You give the person glucose orally, and you measure the tolerance of to that glucose that you have given orally. Then there is a thing called insulin resistance syndrome, also known as syndrome X. It happens usually in patients who are obese and who have type 2 diabetes. So, the type 2 diabetic patients, when the obesity is there as well, there is hyperglycemia associated with hyperinsulinemia, then dyslipidemia and hypertension. And all these lead to coronary artery disease and stroke. We have already studied in stroke and coronary heart disease. The risk factors for those are all the ones that we have just mentioned in this syndrome X. And usually it is produced due to a genetic defect which results in insulin resistance. And it has also been proposed that insulin resistance predisposes to hyperglycemia, which results in hyperinsulinemia. That excessive insulin level then contributes to the high levels of triglycerides and increased sodium retention by renal tubules, thus inducing hypertension. High levels of insulin can stimulate endothelial proliferation to initiate atherosclerosis as well. So this is in totality the syndrome X, or insulin resistance syndrome. Let us take a look at the epidemiology of the disease, the problem statement about diabetes mellitus. It is an iceberg disease. You know that iceberg diseases are those which have a much higher prevalence than what is apparent in the clinical setting. So this is also an iceberg disease. Although increase in both the prevalence and incidence of type 2 diabetes has occurred globally, but there has been especially dramatic in societies in economic transition, that is the newly industrialized countries and in developing countries. So the incidence and prevalence of type 2 diabetes both are higher in societies which are in transition phase, or which are going through the industrialization, or you can call those the developing countries, and our country is also part of this phenomenon. Currently, the number of cases of diabetes worldwide is estimated to be around 347 million, and among these 347 million cases, 90% are of type 2 diabetes. The prevalence of hyperglycemia in communities or in countries or in societies, it depends on the diagnostic criteria that you have chosen for your epidemiological survey. The global prevalence of diabetes in 2008 was estimated to be 10% in adults aged 25 years and above. The prevalence of diabetes is highest in Eastern Mediterranean region and regions of the Americas, where it is 11% for both sexes, and lowest prevalence of diabetes is in the WHO European and Western Pacific regions, where it is 9% for both sexes. So you know that Pakistan is placed in the Eastern Mediterranean region. So we are one of the one of the parts of the world where the prevalence of diabetes is considered to be highest. Now we shall talk about the risk factors that are responsible for diabetes mellitus. So the risk factors may include agent factors, the host factors, the environmental factors. So what are the agent factors? We know that the underlying cause of diabetes is insulin deficiency or resistance, which is absolute in type 1 diabetes and partial in type 2 diabetes. And this insulin deficiency may be due to a wide variety of mechanisms, which are the agent factors. There may be pancreatic disorders, inflammation of the pancreas, neoplasia, or some other disorders such as cystic fibrosis. Or there may be defects in the formation of insulin, that is the synthesis of an abnormal biologically less active insulin molecule which is not effective. The third may be the destruction of beta cells, which are responsible for the production of insulin in pancreas, and this destruction may be due to infections. For example, some viral infections can cause that, or it may be due to some chemical agents. The next one is decreased insulin sensitivity, which may be due to decreased number of adipocyte and monocyte insulin receptors on the receptor cells. Then there are some genetic defects. We know that genetically there may occur a mutation of insulin gene, which may result in non-production or inadequate or defective production of insulin by the pancreas. And finally, there is autoimmunity, where autoimmunity by the body results in destruction of cells, the insulin producing cells in the pancreas, and that results in inadequate or lack of secretion of insulin. The overall effect of these mechanisms is a reduced utilization of glucose, which leads to hyperglycemia, and that is accompanied by glycosuria. Next, in the risk factors that are responsible for diabetes mellitus are the host factors. And the first one among the host factors is the age. We know that diabetes may occur at any age, but surveys indicate that prevalence rises steeply with rising age. As the person grows older, the chances or the risk of acquiring diabetes mellitus increases as well. Type 2 diabetes usually comes to light in the middle years of life and thereafter begins to rise in frequency. Malnutrition related diabetes affects large number of young people. The prognosis is worse in younger diabetics who tend to develop complications earlier than the older diabetics. So this is the age factor which is linked with the diabetes mellitus. Then there is sex. In some countries, for example, United Kingdom, the overall male-female ratio is about equal. But in Southeast Asia and in South Asia, which is our part of the world, an excess of male diabetics has been observed. But this may be due to some error, some observer error, or some other biases. Uh, it may be due to less number of women seeking medical advice for their ailments. That results in less number of diabetic women being registered. So that may be the reason, one of the reasons that is responsible for this disparity among sexes in our part of the world when it comes to diabetes mellitus. Then there are genetic factors. We know that the genetic nature of diabetes is well established. There are a number of studies which have established this fact. It runs in families, we know that. Next is the genetic markers. Type 1 diabetes is associated with the expressions of some genes which are HLA, B8 and B15, and more powerfully with HLA-DR3 and DR4. The highest risk of type 1 diabetes is carried by individuals with both DR3 and DR4 expressions present. On the other hand, type 2 diabetes is not HLA associated. The next are immune mechanisms. There is some evidence of both cell mediated and humoral immunity against islet cells, where the insulin producing cells in the pancreas are destroyed. Then there is obesity, which is strongly linked with diabetes mellitus, and in particular the central type of obesity, which is more prevalent in South Asians, in Pakistanis, is more linked, has a stronger link to type 2 diabetes than the musculoskeletal type of obesity. Next are maternal diabetes. We know that offspring of diabetic pregnancies, including gestational diabetes, are often large and heavy at birth. They tend to develop obesity in childhood and are at high risk of developing type 2 diabetes at an early age. Then there are the environmental risk factors. The first and foremost among the environmental risk factors is the sedentary lifestyle, which is associated with diabetes mellitus. Next is diet. A high saturated fat intake has been linked with the higher risk of impaired glucose tolerance and higher fasting glucose and insulin levels. Dietary fiber has been shown to result in reduced blood glucose and insulin levels in people with type 2 diabetes and impaired glucose tolerance. Malnutrition, protein energy malnutrition in early infancy and childhood may result in partial failure of beta cell function, so that may result in diabetes mellitus. Alcohol consumption is linked with diabetes mellitus. Some viral infections, for example, rubella, mumps, and human Coxsackie virus B4, they are among the viruses that are associated with diabetes mellitus, and they do it by producing autoimmunity, since they mimic some of the antigens that are present in the beta cells of pancreas. Then there are some chemical agents which are known to be toxic to beta cells. For example, alloxan, streptozotocin, the rodenticide Velcor, a high intake of cyanide producing foods, for example, cassava and certain beans, may also have toxic effect on beta cells. And then there are some other factors which may be described as social factors or socioeconomic class. These are also environmental factors as well, which are associated with diabetes mellitus, and these factors may include occupation. Certain occupations have linked to diabetes. Marital status is linked, religion, economic status, education, urbanization, and changes in lifestyle, which are elements of social class. And one of the important epidemiological features of diabetes is that it is now common in lower social classes. Whereas 50 years ago, the gradient was the reverse. 50 years ago, it was more common in higher social classes, but this is now opposite. One reason could be the rapid changes in lifestyle in lower classes. What the higher classes were going through 50 years ago, the lower classes are going through the same transition nowadays. So the incidence has increased in lower classes. So how will you screen somebody for diabetes mellitus? We know screening is important for early diagnosis and prompt treatment. We know that type 2 diabetes is usually found out accidentally. So screening is important for diabetes. So what are various methods? Earlier, the method of urine examination was used. Urine test for glucose 2 hours after a meal was commonly used, and all those with glycosuria were labeled as a diabetic. But this test has a low sensitivity, and if somebody has no glycosuria, does not mean that he or she does not have uh, diabetes mellitus. The other method uses blood sugar testing. In blood sugar testing, the fasting or postprandial or random samples are taken and blood sugar levels are measured in those. Or another way is glucose tolerance test, in which the glucose is given orally, and then it is measured in the blood, and the tolerance to oral intake of glucose is recorded. So blood sugar testing is nowadays the cornerstone of screening, and none of the tests in blood sugar testing alone is adequate for screening. For example, the random blood sugar alone does not give you any specific idea about the diabetic status of the patient, nor does the fasting blood glucose. It is used in combination and serially to label somebody as diabetic or non-diabetic. The other way is to give somebody the glucose tolerance test. So these are two methods for screening of diabetes mellitus. So what are the diagnostic criteria for diabetes mellitus? The WHO recommendations for the diagnostic criteria are, as you can see on your screens, This table shows the diabetes if fasting plasma glucose or 2-hour plasma glucose is more than 200 milligrams per deciliter, or fasting plasma glucose is more than 126 milligrams per deciliter. That will be diabetic, that will be labeled as diabetic. Impaired glucose tolerance will be if fasting plasma glucose is less than 126 milligrams per deciliter, or 2-hour plasma glucose is more than or equal to 140 milligrams per deciliter to 200 milligrams per deciliter. And again, impaired fasting glucose values are given in front of you on your screens. So these are the criteria, the cutoff values which are used for labeling somebody as diabetic or not. So when you go for screening or screening for diabetes mellitus, what will be the target population? Since screening of the whole population is not really possible, nor is it very rewarding, but you can screen high risk groups. What those high risk groups may be? Those may be the age group 40 and over, or the ones with family history of diabetes, they will also be in high risk group, or the obese persons, or the women who have had a baby weighing more than 4.5 kilograms, or the women who show excessive weight gain during pregnancy, or the patients with premature atherosclerosis. These are the high risk groups, and you can use them as target population for screening for diabetes mellitus. Finally, we talk about the prevention for diabetes. Prevention, of course, is the main focus in our subject of community medicine. So, prevention may be of primordial or primary variety, or it may be secondary prevention. When you are focusing on primordial or primary prevention, you can use two strategies. One is the population strategy, the other one is high risk strategy. The population strategy will focus on primordial prevention, that is the prevention of the emergence of risk factors in communities in which they have not yet appeared. The prevention measures comprise of maintenance of normal body weight, or healthy nutritional habits and physical exercise, etc. The nutritional habits include an adequate protein intake, a high intake of dietary fiber. We know that fiber has a protective effect against diabetes mellitus, and avoidance of street foods. Elimination of other well-defined factors which we have talked about previously, that may also result in prevention for prevention from diabetes mellitus. So another thing that can be addressed in primary prevention for non-insulin dependent diabetes, those are the avoidance of certain risk factors, and for example, sedentary lifestyle, overnutrition and obesity, and alcohol, is associated directly with the diabetes mellitus, so that should be avoided. Subjects who are at risk of developing diabetes mellitus, at higher risk, they should avoid diabetogenic drugs like oral contraceptives, etc. They should avoid smoking, high blood pressure, elevated cholesterol, so the chances of atherosclerosis are less. So this is the way you can apply primary prevention. Then there is the secondary prevention for diabetes mellitus. We know that secondary prevention is all about early diagnosis and prompt treatment. So once the diabetes is detected, it must be adequately treated, and the aims of the treatment should be to maintain blood glucose levels as close within the normal limits as is practicable and feasible and possible, to maintain ideal body weight, and the treatment is based on diet alone, or it may be diet and oral anti-diabetic drugs, or hypoglycemic drugs, or it can be diet and insulin. So this way you can manage the diabetes in an adequate manner. Uh, Certain other things that are part of the secondary prevention, these include the glycosylated hemoglobin levels, which should be estimated periodically at half yearly intervals, and this test provides a long term index of glucose control. This test gives you the the state of glucose control which the patient has been in for the past 6 months, and this test is based on the rationale that glucose in the blood is complex to a certain fraction of hemoglobin to an extent proportional to the blood glucose concentration. You will study it in detail in your pathology lectures. So this is one of the other things that is included in secondary prevention. Also, also part of secondary prevention are self-care. We know that a crucial element in secondary prevention is self-care because the diabetics are prone to certain complications of the disease, and they must be able to uphold their own responsibility, the responsibility for their own health by themselves. So that is an element of self-care. Then there are home blood glucose monitoring, which is made much easier nowadays with the advent of with the presence of so many devices, digital devices or glucometers, which can be bought and used at homes to monitor their blood glucose levels routinely. So these are all part of secondary prevention. Very important in diabetes mellitus is the tertiary prevention. We know that diabetes is a major cause of disability through its complications. For example, it can lead to blindness or kidney failure or coronary thrombosis or gangrene of the lower extremities. We all have heard about diabetic foot and diabetic neuropathy and nephropathy, etc. The main objective at the tertiary level is to organize specialized clinics, which may be labeled as diabetic clinics, and units capable of providing diagnostic and management skills of a high order. And there is a great need to establish such clinics in large towns and cities. The tertiary level should also be involved in basic clinical and epidemiological research. It has also been recommended that local and national registries for diabetics should be established. So this is all about diabetes mellitus from community medicine point of view. Remember, we are discussing the non-communicable diseases. In the next session, we will pick another one of the non-communicable diseases and talk about it. Thank you very much. Have a nice day.